I'll be starting today the very basic scene of ophthalmology, and as time goes on, every 2 weeks or 3 weeks, our colleagues will share the necessary knowledge to function in an eye unit effectively. So we just to quickly go through the anatomy. The eye has basically two parts. This is the anterior part and the posterior part. So the anterior part is what we call anterior segment, and it has the lens located inside and also the cornea. And the fluid that bathes the anterior segment is watery, that is known as aqueous humor. If we look at the posterior part, it's a vitreous. The major part is that, which is the main shock absorber of the eye, which absorbs shocks, and also it has in its wall the sensory layer of the eye, the retina. And this part is filled by vitreous, which is gel. So this is very important surgery. The anterior part, watery; posterior part, gel. Now, when we look at the structure again, the eye has again three layers in its wall. The outermost layer is the sclera. The innermost layer is the retina, the sensory part. In between, you have something called choroid or wheel tract, which is the vascular structure of the eye, and it maintains nutrition and waste removal of the eye. Now, if we look at the function of the eye, it basically is the one that will perceive light. So, light rays that come from outside world will go through the cornea and go through the lens and finally fall on the retina. So you can see here when we define the optics of the eye, for practical purposes, we consider if any object is located 6 meters away or 20 feet away, then we consider mathematically it as located at the infinity, and the rays we consider as coming parallel. So when we so the object has to be around 6 meters away for definition purposes. Say we are looking at something near, like something very close by, we're reading a book or reading a computer device, then the objects come very close and there something has to happen inside the eye for this near object to come into focus, because the rays are now coming not parallel. So here, if you can see, with the close focus, the lens becomes more globular. When you look at something far away, lens is thin. It's very thin. Here is globular. So this process is called accommodation. So when we accommodate, we can see something near. Effectively, eye becomes myopic. Oh, it can see near, but you cannot see far. You can try it on yourself and see. When we are looking at something near, we really don't see anything far very clearly. Same thing inside the eye. On the left side, the rays come parallel. You are looking at something far away, and it come to focus. The moment you look at something near, for it to become focused, eye has to become myopic functionally. So the lens structure becomes globular because you can't change the structure of the cornea. So it will come like that and make the visibility a possibility. So now, if we look at the vision, there are attributes of vision, what the vision has. So one thing is, I'll go through them one by one. We have a visual field. So when we look at something, when we look at outside world, we perceive so many things, and that what we see is known as visual field. So there's a superior border, the upper level, beyond which you can't see. There's a lower level at the floor, beyond which you can't see again. And on the sides, you can see on the left side, the right side, and behind whatever you don't see. So that's the visual field. And we'll come to the details of the visual field later. Then visual acuity, number 2. Visual acuity is how clear we see things. Now, if we observe very carefully, if we look at something in the distance, you can see that only the center area is very clear. As you, without moving your eyes, just try to see outside. Outside is not so clear. Center is very clear. So that central area, we say they have the highest visual acuity. The periphery has low visual acuity. Then third component in vision is color vision. We see colors. We see red, we see green, we see yellow. So many colors. So colors have a scientific theory behind it. And we'll go to that also briefly. And finally, contrast, something which doesn't have proper word in single or Tamil, but we'll discuss that also with the help of diagrams to understand, because that is also very important vision when we deal with various diseases. So binocular visual field, visual acuity, color vision, and contrast. Those are the four things that we see, the components in whatever we see. So first we'll go into visual acuity. Now, I think most of us who have worked in eye clinic know what this is. This Snellen's chart is a very old chart and very, very accurate also for most of the practical purposes. It has a top one letter. As you go down, there are 2 letters, 3 letters, 4 letters, like that. It keep on increasing. So we tell that this has a crowding effect. It crowds as you go down, crowding effect. And you can see on the sides. On the right side, there is this 660, 630, 620, like that, various numerals. And on the left side, 2200, 2000, 27. So it's a different type of numerals. So on the left side, what you see are nomination in feet, and the right side in meters. It computes. So what does visual acuity really mean? Now, for say you are looking at 2 stars in the sky in the night, you can see 2 stars. Say by some way you can make them closer together. At this point, you can see those two stars as 2 stars because they fall on 2 places in the retina. If you can make them closer to each, what will happen? The 2 points in the eye will also become closer and closer. Go closer and closer. At one point, they will fall on exactly same place at which point you will see only 1 star. So these stars become closer, 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 and 1 point you just see one blob, not 2 stars. So before that, at this level, there's a minimum angle between the 2 structures, and it is known as minimal angle of resolution. So when this is very low, you see things very clearly. If for diseased eye like diabetic retinopathy, ARM, if this will become larger, and therefore your larger MAR, at which point 2 will be seen as 1. So this logic is used in the Snellen chart. These 2 scientific, but if you can remember, 1 degree has 60 minutes, and one minute has 60 art seconds. In single is ansaketa, kala hatai, kala ekagata, vikala hatai. So like that. So 1 degree, 1 minute, 60 seconds. So if you look at how clear we can see, even at 5 kala, 5 seconds, 5 seconds is 1 minute, 2, 3, 5. At 5, 6, we can see, even at this level, we can see. So that is how our MAR is defined. So each limb of a letter subtends 1 arc minute. The whole letter will subtend 5 arc minutes. Don't think about this too much. Just remember there's a scientific theory behind the size of the letter and the distance from the observer. So there are other charts as well. So this is known as ETDRS chart, or early treatment of diabetic retinopathy study chart, which was used in that study. And this is very accurate, very scientific, and you can see there's crowding is same. There are 5 letters at each letter. So here we give the amount of vision by letter count, how many letters the patient can see. So this is more scientific, more accurate, but only thing is it's very troublesome to use in a busy clinic. So we resort to using Snellen chart. So there's a comparison between Snellen chart and the ETDRS chart. And ETDRS is more accurate with the logma, or the minimum angle of resolution, 2 stars seen as 2 stars at the minimum angle, and you can get the log value. And this is what how it shows. So if you have 6 vision, a Snellen chart, the log value would be 0. Here again, if you have 6 vision here, 6 vision is in US system 2020 feet, 6 in meters, and log value would be 0. So if you, this is very important when you go through orthopedic reports. In orthopedic reports, they give the child vision in usual log values. So where they use the ETDRS or an equivalent, and so if it's a log value 0, it doesn't mean the patient cannot see. The patient can see very clearly, and the vision is normal, right? If you see logma 1 is very low vision, actually, very low vision, and logma 1 is usually seen in newborn infants. In our clinics, we have very limited space in all our clinics. So what we do, we use reverse chart. You can see here the letters are reversed. And then what we do, we have mirror. So the reverse letter chart is on the top of the patient's head, and you have mirror at 3 meters. So now what happens? The patient will see the properly reversed letters, and therefore you can use only 3 meter space. The important thing here is you can have one staff person to guide the patient and record. Otherwise, if you use a normal chart, the space will be doubled, and you can have to have one person to show, another one here with some sort of stick or a wayweller to show the letters. So I have seen this happening in some clinics in the early days, but this is more efficient staff-wise. So we'll ask the patient look at the Snellen chart, and we'll ask him to read the letters. And if he falters, when we know, we record how much he can see. If the patient has cataract, probably he won't be able to see the letters in the Snellen chart. Then what happens? We'll ask, can you see my hand? You'll wave the hand. You'll show your fingers. Can you see my fingers? How many fingers are there? 1 or 2 or 3 raised. So people say, I can see 2 fingers, 3 fingers. So you can say, you will write out how many fingers the patient can see. Say the vision is very bad. If the patient can't see your fingers, then you just wave your hand. So if the patient can see your waving hand, you say HM plus, hand movements plus. If it's a very dense mature cataract, the patient will not be able to see that also. Then of course we'll have to go very close and flash a light and see whether can you see the light. So perception of light, PL vision. If the patient can't see even the PL vision, even there's no PL vision even, you have to alert the doctors and the consultant to see whether there's a problem there. Because if we say no perception of light, NPL means that probably that eye cannot be rescued. There's no function. It's a dead eye probably. So when we say NPL, it's a very serious decision. It's always somebody else has to double check and see, and the consultant also have to see, because probably we will not intervene in any disease if it is really NPL. So you have Snellen chart, letters, keep on counting. At one level, the patient can't see. Say at the mid-level, patient can't see. Then what you do, you will give to the hand something called pinhole. So in this patient, in gentleman, left eye is covered. It's an occluder. You can't see in the left eye. In the right eye, there's another occluder with holes. You can see as a pinhole. So now what happens? He will see through the pinhole. So if in the beginning he not read the whole Snellen chart, but with the pinhole, if you can see down, then we say the patient has a refractive error. Patient has a refractive error. So what are refractive errors? Those are where the error can be corrected with glasses. Those are what are known as refractive errors. So there are 3 main types. One is myopia or nearsightedness, hypermetropia or farsightedness, and number 3 is astigmatism. In myopia, the patient complains that he can't see distance, but near he can see. Hypermetropia, the patient cannot see near, distance may or may not be visible. Whatever he sees is only distant, not near. So he's far-sightedness. In myopia, near-sightedness. Avidura Dushtikati. Far-sighted Dushtikati. In astigmatism, it's just skewed and distorted. Image is distorted. So those three consist and give rise to many other types of refractive errors. So remember, these patients cannot read this in a chart usually, but when you ask them to go through and read through, look through a pinhole, small hole, he can read them. There's a theory in physics, in quantum physics, of how it happens. It's too much to discuss here, but then you know the patient can be corrected with glasses. So when we do eye cams, large eye cams, what we do is we quickly check the vision. So if the vision is low, then we give them a pinhole. If the vision improves, we straight away send the patient for refraction, for vision testing, and give glasses and check the fundus. If we cannot read, even with the pinhole, then what we'll do, we straight away dilate and check the retina fundus to see whether there's a cataract or hemorrhage or some other problem. So that very useful thing is a pinhole where you can do large eye cams very quickly. So when you can see, when you're looking at something far away, that is infinity, if you can see it very clearly, we say that patient has no refractive error, and also that patient has an emmetropic eye. Emmetropic means no error. If the patient is myopic, he can see near, therefore he will see but not distant. So it's a emmetropic eye, not emmetropic, emmetropic eye, and the emmetropic error is myopia. Again, the patient can see far but not near. Hyperopic eye or hypermetropic eye is again emmetropia. So emmetropia can be myopia or hypermetropia. I'll come to the last one later. So in myopia, you will have to use corrective lenses, which are called negative lenses, or concave lenses to correct the error. So the focus here will not be pointed in the vitreous, but will be taken back into the retina and follow the retina. So you can see if you go to the click files, patient will have minus 1D, minus 2D, or minus 3.75D. So it means that patient has myopia of 1 diopter will correct it to 6/6 vision. Minus 2D is large error, minus 3.75 very large error, and 6/6 or 6.9 whatever. So if you see minus D, this D in diopter, that means the patient has a myopic error. So the myopia is a huge subject. I don't want to go into very much detail because that will take our lecture to be very long. But remember here what happens is the axial length or the length of the eye from the cornea into the fovea is longer than in a normal person. So what happens if the light rays come here and focus on normal eye, if the retina is here, myopia is pushed backwards. Therefore, it is focusing on the proper place, but there's no retina there. Retina is going backwards. So then you have to use corrective lenses, which are concave lenses, so that it will go like this and focus on the proper place. In addition, myopia will have, in some myopias, what we call as pathological myopias, over long period of time develop various problems in the eye. So it's very important to follow up a myopia patient properly. So they have excessive increase in axial length relative to the refractive power of the eye. That's a definition of myopia. So it could be, there are so many varieties. So due to variations in the axial length, you can have myopia. If it's short, hypermetropia. So there are other causes as well. So largely we don't know why these things occur in children, especially myopia or hypermetropia. But there are a lot of anomalies which are too much again. But one thing is important, that's disruption of circadian rhythm. So what is circadian rhythm? We know if we take a full day from around 6 p.m. to 6 a.m. is night, is dark. Again, 6 a.m. to 6 p.m. is light. So we say this part is diurnal, daytime, this is nocturnal. So nocturnal. So what happens in diurnal time? We are basically active in the daytime. We go hunt, gather, create, procreate, and do all sorts of things. Nighttime we rest. So nighttime, not only we rest, the body also rests. The hormone system changes. They become into more repair mode. And the daytime they don't repair. They are in active mode, searching for food, searching for partners, searching for uh, shelter and all that. So we work. So this cycle is very important. This cycle is known as circadian rhythm. Now, what happens nowadays? We have light, we have electricity, we have current, we have light. So we work, we wake up and we keep working with the dead of the night. So this structure, this circadian rhythm is disrupted. Then what happens? The body goes into stress mode, and that stress will cause myopia to progress. So there is one explanation why we see people who do excessive near work in childhood, they go into myopia. Better socio-economic conditions, better light, better things. Or we can look up, we can look at TV, watch TV, computers, everything in the night, it will increase. Also, urbanization is associated with more and more myopia incidents. So these are known, proven facts. So the rest of this is too much for you, but usually at newborn, usually the eyes shorter. Therefore, they are hypermetropic. So gradually, by the first 1.5 years, they reduce and become normal. By around 2 to 5 years, they are usually mildly hypermetropic or emetropic or normal. There's no error. By around 5 to 6 years of age, the patient should have normal axial length, and therefore parallel rays will come and focus on the retina. This hypermetropia at birth is the stimulus for eye to develop, grow larger and larger. And gradually it becomes larger, longer, and by around 2 to 3 years, it's usually normal. So most importantly, axial length is the most important factor for hematoprization, and there are so many factors that will work to make it change from the normal pattern. Yeah, so now this part I am going to run because it's too much for anyone. We have very limited time now. Yeah. So just to show that the myopia will make, if it becomes pathological, you keep on increasing, then you have a lot of retinal changes, and usually these patients then are more subject to many changes in the eye, and they can have myopic degeneration, RD, cataract, and glaucoma. So all those 4 things will increase, not in all myopics. Now don't get panicked, only people who have high myopia, like more than -5, -6 diopter errors, should look after for other changes in the eyes, especially RD and glaucoma. Yeah, hypermetropy other way around, eye is short, and therefore the ray should come and fall here, but the eye is not here, is here, is short. Now, this hypermetropia, short eye. So this is not so common as myopia, but it is there. Now, in the days before rubella, it was quite common. You see children having congenital rubella with very short eyes, and therefore they have very, very, very low vision for near. Nowadays, because of the rubella vaccine, we don't see them. It's almost nil, but hypermetropia still can occur. So hypermetropia, I told you, the eye is shorter, and therefore the virtually the image must form behind the retina. So here you have to increase the power of the eye by using convex lenses. So convex will converge more and get the proper focus onto the retina. That's hypermetropia. Now I told you about accommodation in the beginning, where you can make your lens more curved, globular, and focus and make it myopic. So what happens in hypermetropia is that since they can't see, because eye is short, they can't focus retina on the retina, they will use the accommodation, make it globular, so at least they can see the far objects. That's why it's called far-sighted, or in singular, duradrushtikatva. Since they have used all their power to see things in distance, the moment they decide to see near, they can't make it more globular. Therefore, they cannot see near. So only far, not near. Also, because they are activating a very powerful muscle all the time, they usually complain of headache. They have headache is very common among hypermetropes children. Then astigmatism is where the cornea, usual cornea, is not regular. So if you look at the eye, the cornea should look like a part of a ball, like a tennis ball, very circular. Then you have all curvatures are equal, symmetrical. But in astigmatism, is like a rubber ball. You can see this curvature is shorter, this is longer. Therefore, it is not regular. Now what happens? When the light falls on this, it cannot focus properly in one single place. Like this. If you look here, in this way, curvature is short curvature, high curve, low, as a low curve. So any light that falls along this path will go far away. Any light that will come on this path will come shorter. So all these ideally should come and fall in one place. Now there are two places here. So you have one focal area, but not a focal point. Therefore, they cannot see properly at any time. They can't see neither distant nor near. And they also have headaches, and their vision is usually not very good. They are distorted. Astigmatism. So you can see here is myopic and astigmatism. And if you can see this part is hypermetropic astigmatism. So there are so many varieties like simple astigmatism, myopic astigmatism, compound astigmatism. Like that, there are so many depending on where these points lie. If they both lie in anterior into the vitreous, this is a myopic astigmatism, which strategies like this compound astigmatism. So again, too many details, but astigmatism is a place where there is no one single focal point. There are two focal points, like second and the first, and therefore, at any distance, they don't see things very clearly. So all these errors like myopia, hypermetropia, astigmatism, you can subjectively check by doing a test called refraction. So you do refraction. In refraction, what you do, you try to measure the error objectively by using a small instrument like an ophthalmoscope. It's called retinoscopy, and you use that and you can find out whether the patient myopic, hypermetropic, or astigmatic. So that will give you an idea of objective or real true error, objective error. So you cannot give objective error to a patient, then you verify it or you simplify and give it by doing subjective refraction. Subjective refraction. So if you look at a clinic book in your clinics, you will see that the technician will write down RET කියලා. RET means the retinoscopic power. Say plus 2 diopter is the retinal in one eye, right eye. Then left eye, say plus 1.45 diopter. Then he will write getting sub. So subjective refraction, say my combine 1.75 diopter is a comfortable one. Even though the proper one is 2 diopter, only 1.7 can be tolerated on right eye. The left eye maybe 1.5 diopter. I'm just giving an example. So you first verify where the problem is, where exactly whereabouts. Then you verify and give the most comfortable power to the patient to wear ultimately. So that is retinoscopy and refraction. So next day you can go and see in your refraction areas and see what they are doing. So with this power that you get by doing refraction, then you can apply them and give either spectacles, kannadi, or contact lenses, or even you can calculate and do things into your eye and give laser also. And there's number 4, treat amblyopia. I'll come to that later. So basically you have spectacles, contact lenses, laser, and also sometimes you can even do surgery, IOS also, when there are high errors where you can't give meaningful refraction power by giving glasses or contacts. So this is surgery. Now what happens in laser, say LASIK or SMILE or whatever, we saw that the eye has this cornea and the lens. So out of the refraction that happens, where the parallel rays come and get focused on retina, happens at the cornea and the lens, both places. Cornea is responsible for 2/3 of the convergence, and lens is about 1/3. Now we know lens can be changed by accommodation, make it globular or flato, and then you can see near or distance. Cornea you can't, but can't you really? Now say the patient is myopic. Very myopic, what you can do is, you have a cornea here, lens here, in the lens. So if you don't want to wear glasses, if you don't wear a contact lens, what you can do is you can increase the corneal power by changing the shape of it and making more curvature. In that way, you can increase the power by doing a refraction first and apply that power into a computer and compute how much to change the cornea by doing laser. So you can see this video, it will show you how it happens. Hope it will run. Oh, it's not running.
SMILE, known as a minimally invasive and flapless surgery, is the third generation of laser vision correction beyond PRK and LASIK. The femtosecond laser system creates a thin lenticule and a small incision measuring less than 4 millimeters in the intact cornea in a single step. The surgeon manually removes the lenticule through the small incision. No flap needs to be cut, so there is only a minimal disruption to the biomechanics of the cornea. The minimally invasive removal of the lenticule changes the shape of the cornea, thereby correcting the visual defect of the eye.
So you can use this to treat myopia and hypermetropia both. So that we have discussed visual clarity, visual acuity, the use of charts like Snellen chart and ETDRS chart, and errors of visual acuity where you cannot see the chart properly, but with a pinhole you can see to the last line, and then you apply refraction to see whether the patient has myopia, hypermetropia, astigmatism, do glasses, and there's laser also in the frontier nowadays to treat. Only thing, laser is done when the person is more than 20 years of age, because below that the eyes keep changing and you should not do laser on a changing eye. Also, after 50-60 years of age, you wouldn't think of doing laser on the cornea. You would rather take the lens out, because we know that by that time there's a chance of laser, cataract. So you don't want to do two procedures. You just take the lens out and put a new lens in, and that will settle the matter. The second one is visual field, where, so when you look at outside objective world, you can see when you look at something quite in the center, in the far away, while looking at it, you can see that you can see the sides also. You can see up, you can see down, you can see side. But as I said earlier, those peripheral areas are not so clear. The central 2 degrees are very sharp. Central 2 degrees here, very sharp. Yeah, you will read or see someone or whatever the object of interest that you want to see. The outside is not that sharp, but it is very sensitive to movements. So before we became urbanized, if we were in a forest, like hunters, when we travel, when you go, you may be looking at something far away, but suddenly if something moves in the shrubs, you might think of a snake, and even though you know that, you have jumped outside. So that happens because of this area is very sensitive to small movements. So it's evolutionary advantage. And same way, if you look at your visual field, whatever you want to see will become very clear in the center, but the periphery outside is not so clear. So that in that way, the object of interest is kept in focus, and outside will not come and disturb your attention. And after, if I look now, if you think like yourself as a newborn infant, now you are born, you look outside, you can see a visual field, you can superior, inferior, lateral, and you can see. Then if you can, then you find out by how much process one eye, then you know this visual field is made of two visual fields. There's a right field and a left field. There are two visual fields to fuse. So here the right eye, then it has one visual field, left eye also another visual field. So what happens here? The two fields will see the same object from two different angles, and then it will reconstruct the image inside the brain, and then you get a 3D idea. Did you see this one? I'm sorry about all the technical issues. I don't know what's happening here. So a person has a squint. If he has a squint, what will happen? One eye is turned either inside or outside. And therefore, the two images will be different between the two eyes. There will be one here, in one eye there will be proper image, and other may be having some other image. So now they cannot be fused, and therefore there will be confusion in the neurological circuits. Same thing happens here. Here has a hypertrophy turned up, hypertrophy turned down. So this squints, what happens is, because the brain is going to confusion, brain will have to do something about that to avoid confusion, and it will delete or ignore the unwanted image. That's how blindness develops in squints. So then we come to another topic called amblyopia. So amblyopia means low vision in one eye or both eyes while the eye structure is normal. So these are you see in children or children who have not had their eyes checked in their childhood for problems and who have problems, and when you check later on their teenagers' adult lives, you examine the eye for cataract or everything, but you can't see a problem in the structure. Then we call it amblyopia. So eye is normal, anatomy and physiology, but vision is subnormal. So it happens because of vision deprivation, loss of vision in the childhood. So vision is not equal in both eyes, and therefore the binocular vision cannot develop. And usually, if you correct the problem in whatever the eye, it can be corrected until up to a certain age. Usually, it is taken as 8 years. 8 years. So before 8 years, you have to check vision in children. So in other countries, the best birthday gift you can give to a child is having his or her eyes checked at the age of 2 years and see whether he has adult level of vision, and if not, to go and investigate and treat. In Sri Lanka, what happens, there's something called SMI or school medical inspection, where PHIs and PHMs can go and check the vision, and they will screen and see. So if there's squint or if there's a low vision, they will through the MOH into the nearest eye clinic, and then we have to investigate. So this method is quite effective, but it can be improved a lot. So causes of amblyopia. So squints, obviously. So we have one eye looking straight, other eye looking sideways or inside. So what happens? There are two images, as I said. This one gives a proper image. There's another image which is not wanted, and therefore it has to be deleted, removed, and that will cause the eye to go into blindness. So childhood cataracts, again. So you have your eye, then you have a lens, and there's a cataract here. Now what happens? The light cannot go out inside, and therefore there will form deprivation. There's no form for the eye to develop. I told you at birth there's a bit of hypermetropia, and because of this, there will be increased axial length development in the eye to mature adult levels. So when there's no form, no light, it will remain astigmatic, hypermetropic, and therefore, since again the eye will have problem again. The problem is it cannot fuse the two images together. There will be one eye, there will be proper image. Other one, there's no image. Since these cannot be fused together in the brain, and therefore this one has to be ignored. So again, this one also will cause amblyopia. And refractive errors, myopia, hypermetropia, astigmatism. Especially hypermetropia will give rise to amblyopia. Why? They cannot see near. Even distance is seen with quite a lot of accommodation, which gives rise to headache, and sometimes it can fail, and they might not be seeing either distance or near. So they are more prone to loss of vision without any structural problem in the eyes. And if you get myopia, at least they can see near. So if their near vision is not that bad and there's no huge myopic error, they might not go into amblyopia like hypermetropia. They might retain some of their vision. But of course, if the myopia is very large, of course, then it will not be able to retain the vision and to go into amblyopia. So those three: squints, childhood cataracts and uncorrected refractive errors will cause amblyopia. So in children, when they come to clinic, one thing that we usually check is check number one, whether their eyes are straight or not, whether they're straight or not. Then we look at their fundi to see whether fundi can be visible or not. If they are not visible, there can be a media opacity like a cataract or some other corneal problem or a vitreous problem. Then number three, we'll check their vision, and there's a problem, we'll check for refractive errors. Those three things are mandatory in any child who comes to eye clinic. And they're mandatory anyway to any child. So they will catch up either at the school or probably they should better be checked at their age of 2 years of age. Remember, squints can cause amblyopia as we saw. This one we discussed because there are two dissimilar images between the two eyes. But other way around can also occur. Say you have two eyes, normal, and one eye develops a corneal opacity, corneal ulcer. Then what happens? Because there's no vision, they start deviating outside or inside. So amblyopia can cause squints. That's also a problem. So when you have some problem, some trauma, some epithelial defect, you come to the ward, you pad and keep. Sometimes it is not so good. A very small child, better not to pad also. Just give a antibiotic can, ointment antibiotic can, see what happens. If you pad, there's a risk of amblyopia even for 2-3 days. The patient get a cut cornea, you suture, you repair, and after that everything is fine, but still you will have to do something about the risk of amblyopia. After all that is done, if you don't treat amblyopia, the patient will be blind in spite of all your good efforts. So that's amblyopia. So we discussed visual acuity. We discussed visual field in very, very small format. We discussed about amblyopia. And next one would be color. So color is a huge subject again, especially in outside ophthalmology, in camera, photography, advertising is a very huge subject. Now, if we take the energy in the cosmos, there are so many rays going on everywhere. And so we have very large waves, very small waves, like here X-rays that we use in our medical setups, gamma rays that we use for treatment, cutting, ultraviolet, which we don't see, but they are there. And also infrared also, we cannot see, but you use these cameras to operate. The microwave that we use commonly in our heating our food, the radius is very large, very large. They are sometimes kilometers large. The waves are very large. So most of these you don't see, you can't actually perceive. There's no way of perceiving them because we don't have receptor. We can have ear, eye, tongue, skin, but they don't detect these rays. What is visible is a narrow band of all these rays that are in the cosmos, very small area, and that will reconstruct our entire outside universe. So if we look at that small area from around 300 to around 900 and 700 nanometers, that area is visible. Now, all these rays that are there will be different. In the eye, what happens? You have a three-cone system in the eye, which is sensitive to each of the basic colors like red, yellow, and green. Then what happens? They can construct and give us various colors. So colors are not really colors. Colors tell you that there are different wavelengths that are reflected from the surfaces. So it's a huge subject again. In the truest physics sense, there's nothing called color. These are just wavelengths creating a mirage in your perception. But it's a beautiful perception. Now, if you look at the color wheel used in printing, so here you have here, starting here is a very high frequency or 300 nanometer wavelength. As you go along this, they become larger and larger, and here you have got 700 nanometer wavelength. So like a extended rainbow in a wheel like. And each pie that you look at, if you watch carefully, they have the same color but different intensity. Here is very, very high hue, low hue, high hue, low hue. So here yellow become different. So this maps almost all the colors that can be seen in the universe. And if you go into more and more subtle details, you can create millions of colors like in modern day Photoshop and Lightroom applications in computers. And these cone systems are different, have different sensitivity. Usually, the females see more colors than males. The male sensitive 10% less. So if you go with your girlfriend or wife to select a sari or a gown, they will keep on picking between two colors, and the husband or the boyfriend will not see the difference. That's because our system is not able to see that color, but female system is more sensitive. So those are the basics that we have discussed. So we try to go through the attributes of vision. So when you look at something outside world, you will see visual field, and visual field is made of two visual fields, right and the left field, and in the center is very sharp, the macular region. That's where we usually move our eyes to see the objects of interest, which is very sharp. The outside, they are not so sensitive, but they are more sensitive movements. Any small movement is more sensitive. And this is a visual field. And for this to occur, the vision in both has to be almost equal to the small change horizontally. Then they can be fused in the brain and construct a 3D image. So when we describe things about visual fields, the whole visual field, when we discuss about the acuity here, it's about visual acuity, where we should measure usually a Snellen chart, but also there are other charts also that you can make use of in contractors. Yeah. Then we come to the last part, that's contrast. Very small this thing. So contrast, what is contrast? Now, contrast is something where if you see the top things, the top line here, there's a very stark black against a white background. If you look here, you can see, you can make out the letters very faintly, but there's a huge difference. They are almost equal. So this is another chart that is used in research work in eye. It's called Perry-Robson contrast sensitivity chart. So we say that here you have high contrast and here you have low contrast. Now, during daytime, when you have a lot of light, you have high contrast usually. During night time, when the light changes, in Sinhala we say gomang velawa or twilight and dusk. Twilight, dusk. At that time, there's very low amount of light, daylight, and therefore you have a low contrast situation like this. Now, if you look at the bottom picture here, the low contrast one. Like if you go to Haputale or Norelia, in a misty time, this is how you see things. Same thing happens during the transition from night to day or day to night. So this is very important in some diseases like glaucoma, where not only you lose your visual field, like here, glaucoma, you lose visual field, and also you lose contrast also. So when you check vision in a standard click setting where high contrast chart, they will read all the letters. So you are happy, patient happy, give glasses, you send him home. Next day he comes and says, doctor, I can't read, I can't drive, I can't see in the night. And you say, no, glass is correct. The problem is, it's not the acuity, not the field, it's the contrast. So contrast is low. Same thing happens in cataract also. You might have NST cataract, 6-6 vision, but your contrast is low. You think there's a cataract, but he can 6-6, therefore no need to operate. But if he's a driver, he definitely can't drive during these transition light times, and therefore he has to go undergo surgery to increase his contrast, not the acuity, not the field, to increase the contrast. So that's the importance of contrast. Same thing happens when you have color contrast, where if you have a red background with a green color, is high contrast. Their colors are completely different in their wavelengths. So we know in a homecoming, when you wear a red sari and you take a photograph in a green background in a lush forest area, it becomes very beautiful because of the high contrast, and therefore it's very dramatic. Same way, if you by any chance ask the bride to wear a green gown after going away in a green area, what will happen? There will be low contrast and therefore not much of a drama, very, very subdued. So these things are quite useful in photography and cinematography, where depending on the scene in cinema or teledrama, they create the background and create the costumes to increase the drama or reduce the drama. So the contrast is very important. It's not usually tested routinely in our clinics, but should know there's something like that. And when patients have good vision and still come to low vision, probably is because of the loss of contrast. So again, now we have gone through basics of eye, the vision, visual acuity, visual field, contrast, and color. So those are usually adequate to run through, and as you go on, you will see more and more. Especially when you do squints, you will go more deep into amblyopia again by Dr. Hirani. So I think we should conclude here now. Any questions? So we will record this also, and we'll be uploading into YouTube also, and we'll notify the next date for the next lecture. Thank you. The retina, the rays have to come parallel to the eye. So for that to happen, the rays have to come, the light rays have to come from far away. You can see these lights are parallel, so they have to come from far away. Usually that is from the infinity. So just to go through the rays, when we look at the eye, the rays, the light rays that follow the retina have to come parallel for it to come and focus on the retina precisely. So we know rays come parallelly, light, when the object is located at the infinity, far away.